Video sharing. No? Optimize solution.
Yeah, I think now it will play.
Let me see.
Yeah, slides are moving. Yeah.
Lights are there.
Lights are there.
Is it video?
Yes,
Yes,
yes.
sir. Yes.
playing.
Now started. Now started. Yes.
Playing?
Yes.
Yeah, it's playing.
Yes,
It's
yes.
playing,
Now
sir.
it's good.
Playing.
Okay,
Yes.
that's it. Okay, right.
So where we start?
All right.
Yeah.
Right, I'm ready whenever you are.
Yeah, in 4 minutes, I will start at the sharp 5.
5
Just 4
o'clock.
minutes.
Because we already announced 5 p.m.
Yeah, I know.
Yes.
I know.
Mm.
All mute. Everybody mute so that.
Yeah. Please, all members, mute your phone.
Mute. Otherwise, disturbance.
Yeah. Hello, Baba.
Suresh, you can record this, and if any of the postgraduates want to have it, you can give them a copy. No problem.
Recording.
Yeah.
You can record this, and
Yes,
when anybody wants to, you can share it
Yeah.
with them.
Yes, yes. The link can be shared.
Maybe helpful for exam going.
Yes, right, sir.
So we can start. Suresh.
Good evening, all. On the behalf of AOI Kerala State Branch, I welcome Professor Dr. Mohan Kameswaran sir, Padma Shri Mohan Kameswaran sir, to deliver the lecture on Meniere's disease. I welcome Dr. Professor Salkumar sir to host the session, and over to Salkumar sir.
Sir, Mohan Kameswaran, as all of you know, doesn't require any introduction. From very early stage, he attained a name, and his father is a well-known ENT surgeon in Madurai and later transferred to Madras, Professor Kameswaran. If anybody asks who is Kameswaran, just he's the big ENT man. And that man's son, he surpassed his father's abilities and became much more eminent person and the owner of MARF, that is Madras ENT Research Foundation, Mohan Kameswaran. I'm very happy that we did together our post-graduation in Madras Medical College. They were long back in 77, 79. So he is a good orator, he is a good demonstrator, and he is a good friend. Even though he is so big a man, he is a very good friend of ENT fraternity. So I welcome Mohan Kameswaran to deliver the talk now on Veneers disease. Okay, Mohan.
Thank you, Salil. It's 40 years, I think, since we have both known each other very closely. And I think even then we were very, very close, even as postgraduates and students. It was a real pleasure, and I'm so happy today to see you. It's been a little bit of a gap in between, but I think friendships like ours don't mind gaps.
Yeah, right.
Still
Right.
continue the same. So it's really a joy for me to see you, and I particularly thank President Suresh Kumar for this opportunity. I know he's doing a fantastic job in AOI Kerala. I keep seeing again and again so much of academic activities happening. In fact, I think you are actually a bit of an incentive for other AOI state branches. So keep it up, Suresh. It's wonderful. In fact, I was wondering what I should talk about, and Suresh suggested many years because he said it's something which people need to know, and also because it's a topic which is of relevance to every ENT surgeon. So it doesn't matter whether you're a fantastic surgeon or a physician, but it's something which every one of us is going to be seeing.
Yeah, others unmute. Mute. Others mute. Please mute.
Can I request everyone to mute their phone and mic, please? Yeah, thank you. Right. So now I'll share my screen. So hopefully should come to you. Is that seen now?
Yeah, can I see? Yes, see.
Are you seeing the screen?
Yeah, your slides.
Yeah. Okay. Right. So I'm going to be talking about Meniere's disease, basics to advanced. Now, it's the second most common peripheral vestibular disorder. Because the most common, of course, is benign paroxysmal positional vertigo. And this is the next most common peripheral vestibular disorder. And the characteristic finding, of course, is endolymphatic head drops. So classically, it presents with acute rotatory vertigo combined with nausea, vomiting, and anxiety. Anxiety is part of the syndrome, actually. And vertigo will last usually from a few minutes, or 20 minutes, to over 24 hours. And it's episodic, meaning that it won't be there continuously, but it comes in bouts. And it's also characterized by a unilateral low frequency or low tone fluctuant hearing loss, becoming more permanent in later stages. The fluctuation stops in later stages. And another classical finding, of course, is tinnitus. And tinnitus is usually quite significant because tinnitus precedes vertigo. So a patient, when they, particularly seasoned patients, when they know that the tinnitus is becoming more intense, they know they're going to get vertigo and start getting prepared for the vertigo. So tinnitus is a prelude in many ways to vertigo. It will always be there. There's always a baseline tinnitus, but during or just preceding an attack of vertigo, the tinnitus intensity will usually go up. And now, endolymphatic sac was very early in being described by a gentleman called Domenico Cortinino. He is an Italian anatomist, and as early as 1760, at the age of 24. But remarkably, Meniere's disease was first described by Prosper Meniere, after whom it's named, in 1861. Now, what is significant, I think, is something which most ENT surgeons have to know, is that Meniere described Meniere's disease with all the fine features of Meniere's disease much before we knew even before the vestibular system was known. We knew that the vestibular system was responsible for balance. So Meniere's disease was described in 1861 by Prosper Meniere even before the vestibular system's role in balance was elucidated by physiologists. So now, how do we define Meniere's disease? Now, actually, the classical American Academy of Otolaryngology Head and Neck Surgery, AOHNS criteria was laid out in 1995. And this was revised by the Barony Society in 2015 and as recently as 2020. So there are two categories: definite Meniere's disease. Here, there are 2 or more spontaneous attacks of vertigo, each lasting 20 minutes to 12 hours. Second category is audiometrically documented fluctuating low to mid frequency hearing loss in the affected. Can I ask everyone to mute their
Mute
mics?
your phone.
Please mute your mics. Audiometrically documented fluctuating low to mid frequency hearing loss in the affected ear, or at least one occasion before and during or after one episode of vertigo. That means there is you've documented hearing loss in the low or mid frequency, and before and after the attack also is documented. Fluctuating oral symptoms, which include hearing loss, tinnitus, or fullness of the affected ear. And of course, other causes excluded by the other tests. Now, other criteria is known as a probable Meniere's disease, where all is exactly the same, excepting that this audiometric documentation is missing. So they don't have a documented audio, but you have seen the patient. The patient has got classical history, classical presentation, documented oral symptoms, and you know that.
Padikara, mute. You mute your system.
Yeah, please mute your mic, please. interfering with the talk.
This is John Padikar.
John, okay. Okay. Right. So then comes the pathophysiology. Now, pathophysiology basically is overproduction or malabsorption of the endolymph. That means either it's being excessively produced or it is not being absorbed enough. So either way, the pressure in the endolymph system goes up and resulting in an endolymphatic hair drops. The anterior part of the inner ear, that is the cochlea and the saccule, is most commonly affected, maximally affected. If you do a postmortem, that's where you find most of the pathology. But as the disease progresses, also involves the utricle and the semicircular canal ampullae. Finally, in very established Meniere's disease, if we find that every aspect of the inner ear, the cochlea, the entire labyrinth, and the semicircular canal, everything is equally or affected equally. The essential micropathology is that there is periodic ruptures of the membranous labyrinth, which means that there is a leakage of the endolymph, which is rich in potassium, as you all know, into the perilymph. And this results in those acute Meniere's attacks. So it's a leakage of the perilymph into the endolymph through micro ruptures is what leads to Meniere's disease. And this leads ultimately to hair cell death, selectively the type 2 hair cells, and mechanical disruption of the inner ear with dilatation of the utricle and saccule. There's also a fascinating association between migraine and Meniere's disease. Many Meniere's disease patients will also have associated migraine. And, this is quite often when you have a patient with Meniere's disease, you talk to them, they will also tell you that I have a history of migraine in the past. And this can be confusing to the clinician because when you're trying to differentiate between Meniere's and migrainous vertigo or vestibular migraine, there can be a lot of overlapping areas, but there is a strong association between these two. And the other way around, you also know that in migraine patients, there are about almost 12 to 35% is reported. Many of them also develop Meniere's disease. So there is a strong association, which is not understood. Why this happens, we don't know. But certainly there is a strong clinical association between the two. What are the etiological factors? There is a familial type of Meniere's disease, and this is a genetic disorder with a particular autosomal dominant, HLA-B8, DR3, and CW7. These are the genes which are implicated. And anatomically, there may be a small vestibular aqueduct, and there may be trauma, history of trauma, physical or acoustic, sometimes following viral infections. There is also allergy has been implicated. Autoimmunity has been implicated. Very little evidence as such for that, but whenever we have a disease with unknown etiology, one of the things which is labeled as autoimmune. And then, of course, psychosomatic and personality features and all, because there's a strong association with the psychosomatic disorders with stress and so on. The characteristic history is that of episodic vertigo with unilateral fluctuating hearing loss, tinnitus, as I already described to you, with a sense of oral fullness. Many of them will not complain of pain, but they'll certainly say there is a feeling of fullness of the ear or discomfort of the ear. And there are supportive diagnostic tests. We'll talk about it in detail, but audiometry has a significant role. Electrocochleography is one of the few tests which is almost, diagnostic of Meniere's. And then video and histogramography, we hit WEMP, caloric tests, and so on. We'll talk about it in a minute. And you have to exclude other causes. So MRI will say why, because there are many examples, and blood tests also may be relevant. Now the audiometry, if you see, audiometry, there's an early phase, a mid phase, and a late phase. The early phase, as you can see, mainly affects the low frequency. In other words, the apex of the cochlea. So the low frequency is what is affected in the early phase. As the disease progresses, you start getting a peaked pattern. That is, the low frequency and the high frequency are affected. The mid frequencies are relatively spared. So you have a kind of a peak or a tent kind of pattern. But later on, the entire low, mid, and high frequencies are all equally affected, and you start getting the cold pattern.
God. Voice gone? No voice. Oh.
Okay, sorry.
Okay. It's okay.
Here, it's a flat pattern. So you get a low, mid, and high frequency all completely affected. So basically, starting with low frequency, then going on to low and high frequency, and finally a flat audiogram where all the frequencies are affected. Okay, so these are the audiometric findings. ABR, is not particularly pathognomonic or diagnostic of Meniere's, but it's still important because you have to rule out many retrocochlear lesions, and ABR is good for that. To rule if there's a vestibular schwannoma, for example, some of them may mimic very much the Meniere's disease, especially in the earlier stages, and you need to have a differentiation. And there is classically the ABR is very, very helpful in diagnosing a retrocochlear pathology like an acoustic neuroma. Now, this is something new, so I'm going to talk about a few new things which are now coming up. This is known as CHAMP, and this is cochlear hair drops analysis masking procedure. Now, it is very, very helpful in diagnosing Meniere's disease, particularly active Meniere's disease, and also see the progression of the Meniere's disease. Basically, what it does is it uses high-pass noise masking to analyze traveling wave velocity in the basal membrane. We know that in Meniere's, because of the hair drops, the stiffness of the basal membrane increases. So this will lead to an increase in the traveling wave velocity, and this is shown in the form of reduced. You can see the latencies. This is normal, and here you can see that the latencies are reduced compared to the normal. So this is quite classical, and it's quite easy to do. It's not very difficult to do. A good audiology department already has the setup for this. It's all that it takes is a little more time to do it. And an audiologist who's trained in this particular procedure. But this is now very much in the fore. It's coming up. And CHAMP, I'm pretty sure you'll hear more and more. And for the postgraduates who are going for exam, you need to know about it. Please read up about CHAMP. It's important, but basically enough to know that it is a procedure which is based on the high pass noise masking to analyze the traveling wave velocity in the basal membrane. The stacked ABR. Now, this is an interesting test, which is basically, it was brought in more to diagnose very small, very, very tiny acoustic tumors, where it may be so small that sometimes even an MRI, if it's not properly done, you may miss out. But this test will pick it up. It's extremely sensitive, and it's usually done by evaluating the low frequency nerve fibers and summing the synchronized neural activity across 5 frequencies. In other words, your ABR is usually more in the high frequencies are more often affected. Here, all the 5 frequencies across the frequency spectrum is analyzed and it is put together, and it will pick up very, very early acoustic tumors. It's also now being used to differentiate patients from Meniere's from acoustic tumors. A very, very sensitive test. VOG, I'm sure many of you have seen it and you're doing it. Video oculography, it scans the eye movement through high resolution infrared video cameras, and it's a test for the vestibulo-ocular reflex. Electrocochleography is a pretty important test in Meniere's disease. In fact, it's one of the tests which is invariably diagnostic of Meniere's disease. So what does it do? It measures the cochlear's electrical response and auditory nerve activity. In Meniere's disease, this due to the distension of the basal membrane into the scala tympani, this causes an increase in the asymmetry of its vibration, the basal membrane. And the summation potential is larger and more negative than normal. So this is the key. The SP, the summation potential, is larger and more negative than normal. So when you're looking at the SP-AP ratio, or the summating potential action potential ratio, it is higher than 1:3. It's known as a lazy W pattern. Lazy W pattern. I'll show you in a minute what I mean. So widened summating potential action potential complex, more than seconds. So this is quite pathognomonic of Meniere's disease or endolymphatic hydrops. There's also a very small distorted cochlear microphonics. That's not very important. Now, this is the electrocochleography. If you look at the upper part, you can see there's normal electrocochleography. Now, the lower part this is what I call a lazy W pattern. So this is the summation potential action, but summation potential is very much increased. And this leads to this lazy W pattern, typical of Meniere's disease. This is another new test which is now coming up. It's known as the A number. So it's an auditory nerve overlap waveform. Here, it's actually a variant of the electrocochleography technique. And in low frequency hearing loss, it can be debilitating, and majority of speech and background are in the low frequencies. Now, this test will particularly pick up the changes in the apical half of the cochlear turn. And we all know that in Meniere's disease, at least the earlier part, the main part which is affected initially, the apical half of the cochlear turn. So this changes in this A nerve is very, very sensitive for picking up early Meniere's. So this is another test which is coming up. WEMP, we all know, abnormal seen the reduction of more than 40%. Greater than 3:1 ratio can be used to confirm the site of lesion. And in patients with severe to profound hearing loss, it helps to distinguish atypical Meniere's disease from superior canal dehiscence syndrome, where it's actually increased, or in perilymph fistula. So this is a very helpful test for that. In Meniere's disease, WEMP amplitude initially can be increased in early Meniere's disease, but later on it fluctuates opposite to the hearing, and probably due to the cyclical background. Absent WEMP in advanced disease, causes the collapse of the cycle. When performed within...
All of you mute.
Can you all please mute your mics? Yeah. when performed within 24 hours of a Meniere's attack, WEMP is abnormal in many of the patients. So immediately after the acute attack, WEMP is abnormal. But then after about 48 hours, if you test in the same patient, WEMP would have returned to normal. So the change in WEMP is temporary. It usually is noted immediately after the acute attack, but later on it will return to normal. Can I ask everyone to mute their mic, please? Can you
Jayaprabha,
please mute your mic, all of you?
മാറ്റാൻ പറ്റുന്നില്ല അതെ.
he could not do it.
Not able to do it? Okay. Okay. Now, when you're checking the another important thing that is coming up is known as a furosemide loading WEMP, or what is known as FWEMP. Basically, CWEMP rises after furosemide administration in patients. So usually after giving furosemide, 1 hour later, if you go and test, then you'll find that the CWEMP is rising, and this is quite typical of Meniere's disease.
Diagnosis.
Now, video head impulse test, VHIT, is used to measure the vestibular ocular reflex, and it is very helpful to distinguish peripheral from central lesions. Now, basically, VORs in all the semicircular canals are tested, and it's usually unaffected in Meniere's disease. The caloric test, however, is one of the oldest tests that we have, but it is a test which is quite classical because in Meniere's disease, it's invariably affected. There's a peripheral lesion and you have a canal paresis. And usually it's about almost 50 to 75% of patients with Meniere's disease, you will find that the caloric is reduced in these patients. And the VHIT is normal. So the dissociation between reduced caloric and a normal VHIT. Now, this is very specific marker for Meniere's disease. So, in fact, a patient who has a normal VHIT, reduced caloric, so this dissociation is classical of Meniere's disease, and it is, it is almost pathognomonic of Meniere's disease. It will differentiate it from other vestibular disorders like migraine and other vestibular disorders. Now, glycerol dehydration test is another very old test, but still it's a useful test, and it's again once again becoming a little more popular. In fact, it was used to be very popular when people like Salil and I, we were postgraduates, we were all studying about it.
Yeah.
And then in between it went into a lull. But now again, Salil is coming back into fashion, like clothes coming into fashion after many years. Now, basically, you have you check the audiogram, baseline audiogram, and you give 100 grams of 95%. Mix it with the equal volume of water, and then you give it to the patient. After that, you do the test after 90 minutes and 3 hours. And a positive test means that there is an improvement of 10 decibel or more in pure tone audiogram, or an improvement of 10% of speech discrimination scores. So either PTA shows 10 dB or more improvement, or speech discrimination scores improved by 10% or more, or then improvement in postural control also. So basically, this test tells you that there is a high drop, and the moment you give glycerol, which is a weak diuretic, the pressure comes down, and then immediately the test is improved. Now, what is the significance of this test? This test is usually positive in the earliest stages of the disease. And it's also, if you have a positive test, that's a case that you can take up for an endolymphatic sac procedure. So if you have a positive glycerol dehydration test, that's the patient who is going to benefit from an endolymphatic sac procedure. So in fact, previously we used to say that positive glycerol dehydration test is almost a mandatory requirement before you take up a patient for endolymphatic sac procedure. Now, this is another interesting test, wideband acoustic emittance. So 226 hertz to 8 kilohertz. So basically, when there is an increase in the pressure inside the cochlea, that causes the pressure, causes the footplate of the stapes to move out towards the middle ear. So the pressure causes a movement outside, and this limits the movement of the ossicular chain to some extent. Now, this is picked up by the emittance, and that can be used as a test for picking out endolymphatic hydrops. So it's a very, very sensitive test. Not many centers do it, but it's a theoretical interest because it confirms that there is a pressure buildup inside which is causing the foot plate to move out. Imaging, what about imaging? No, basically, imaging is not a very diagnostic thing. Although there have been many reports, but I just tell you what's available today. We don't diagnose Meniere's disease by imaging. We usually use imaging to rule out or exclude other pathologies which can mimic Meniere's disease. So, whenever you suspect Meniere's disease, and if it's not really responding very well, then because imaging is quite important. There's something called hydrops MRI, which is being propagated now. It is supposed to differentiate Meniere's disease from vestibular migraine, and it's gadolinium-based MRI with 3D flare. And it says actually it's based on the principle that combination of endolymphatic hydrops with increased perilymph enhancement will improve the sensitivity and specificity for Meniere's disease. So you can pick it up. And there is something called SURI, that is inversion of saccule to utricle ratio on an oblique sagittal section. This is a marker for endolymphatic hydrops. But mind you, all these are all, I'm just quoting from literature, none of them are now, I would say, standard in practice. That means that, this is not something that you have to diagnose. But it is, all these are available today. CT, what about CT? Well, there's nothing specific in CT. That's very, very important. There have been some theories, like, lack of periaqueductal pneumatization, short vestibular aqueduct, narrow vestibular aqueduct, and so on. But none of them are really, none of them will have stood the test of real scientific question. Blood tests more to rule out any immune-mediated diseases, particularly when the signs and symptoms are bilateral. So, usual tests, cholesterol, thyroid function. There's some theory that hypothyroidism may be associated with Meniere's disease, or there's an association between the two. But certain autoimmune tests like C-reactive protein, immunoglobulins, and particularly the anti-cochlear antibody or anti-68KD. Now, this also has been shown to be positive in some Meniere's disease patients. So what about the management? Management, basically, today, the mainstay of management is a salt-restricted diet. And you limit your salt intake to 1.5 to 2 grams per day, but certainly not exceeding 4 grams per day. Avoid CATs, caffeine, alcohol, tobacco, tension, and salt. So this is the mantra for Meniere's disease patients. Now, what about drugs? Well, the only drug which has been unequivocally shown to work in Meniere's disease is a diuretic. And the thiazide diuretics are preferred. I usually use indapamide, which is a drug which is used by cardiologists quite often for hypertension. But indapamide is a very, very good. It's known as Natrelix SR. The indapamide is a very good drug because it does not deplete the potassium so much, and it lowers the sodium. So it's a very effective drug. And generally speaking, in initial phase, acute phase, you may have to give it every day, but later on you taper it down to initially, alternate days, and then maybe can you hear me now? Hello? Can you hear me?
Yes.
Yeah, okay. Right. So basically, diuretics. The diuretics are the mainstay of the management. Beta histine. What about beta histine? Is a lot of controversy, a lot of proponents, opponents, both sides very strongly, suggesting. But the fact of the matter is almost all of us give it. And then, many patients say it works very well. Many patients will swear by it, in fact. But if you ask, is there a Cochrane review which will tell you unequivocally, a blinded, double-blind study which shows no, there's no double-blind study. In many countries, for example, in the US, it's not FDA. So it cannot be given in the US. So basically, so beta histine has some role, but it's very controversial. Corticosteroids, yes, in the acute phase. In the acute phase, corticosteroids are given as an anti-inflammatory action mainly, and it helps certainly in patients for resolving the vertigo. Long-term, vestibular rehabilitation therapy, intratympanic steroids, and there's a small role for surgery, which we will talk about. What about intratympanic medication? Now, as early as 1956, Schucknecht reported use of intratympanic streptomycin for treatment of Meniere's disease. Keep in mind that the round window membrane is a semi-permeable membrane having 3 layers, and it gives a portal of entry of medication to the inner ear. And average thickness is 70 micrometer. But always the golden rule is you never do a vestibular ablation bilaterally. It's always done only on one side. Because if you do it bilaterally, you run the risk of a complete vestibular ablation both sides, leading to a permanent disability known as a Dandy syndrome. So bilateral vestibulopathy. That's one of the worst disorders that you can give. Much worse than any attack of Meniere's that you can have. Right. Now, intratympanic treatment, when you talk about ablation versus alteration, when you're ablating with a drug like aminoglycoside, you have a vertigo control of about 77%, 200%, depending on whose literature you're reading. But there is a hearing loss of up to 30%. So this has to be kept in mind. Advantage is you're giving a very high dose into the cochlea without giving it into the bloodstream. It's minimally invasive. Systemic side effects are avoided. Method of administration, you can directly inject, you can put in a grommet and give through that. You can have a microwave, the round window microcatheters. In future, maybe nano-based drug delivery route. Intratympanic, nowadays, the drug that we use intratympanically is a gentamicin, where you have a vertigo control in about 70 to 80%, but leads to hearing loss in about 10%. That has to be kept in mind always. The patient has to be informed that even though the drug we are giving, gentamicin, is less ototoxic, more vestibular toxic. In spite of that, in some patients, in about 10 to 15% of patients, there may be some hearing loss. So that they have to be prepared for that. You have to get a consent for that from them. And sometimes the results are temporary, and there may be some regeneration of the vestibular epithelium. Intratympanic steroids. Now, this many people give, but many people also don't approve. So both, it's again one of those controversial things. But the advantage is, it doesn't do any great side effects. It may work, it may not work, but there's no great side effects from this. It's a second-line therapy based on the international consensus on Meniere's disease. When they say medical therapies have failed, then try this. There's no harm. The drug which we give is dexamethasone. Usually, it's given twice a week, sometimes once a week, long term. And, basically the drug has very few side effects, so there's no harm in giving it. It works on the principle that it's an anti-inflammatory agent inside the cochlea and the vestibule. Vestibular rehabilitation therapy was first proposed very, very early by Cawthorne and Cooksey. Terence Cawthorne, the amazing man, everybody needs to know about him. He was a professor of otolaryngology at Edinburgh more than 100 years ago. He was an amazing surgeon. I keep on telling this to my students who come here. So Terence Cawthorne was the first to do a 3-canal labyrinthectomy. So he did a 3-canal labyrinthectomy at a time when he didn't have a microscope. There was no microscope, no drill. So with a mallet and gouge and a binocular loop, he did a 3-canal labyrinthectomy and preserved the facial nerve. So that is the skill of the man. So Terence Cawthorne, he was a surgeon to the royal family. But sadly, he died a depressed man with having committed suicide, because he was unfortunately hauled up in a court by a patient whom he operated for extensive cholesteatoma, and the patient had facial palsy. Patient sued him in the court. Remember, it's more than 100 years ago. And he was so heartbroken by that he went and committed suicide. It's a very sad ending to a very, very great surgeon. But anyway, he was the one who first put forth the vestibular rehabilitation therapy, and this was modified later by branch. And so, it is what we do nowadays is the branch modification of the Cawthorne-Cooksie exercises. Now, what about surgery? Now, surgery, I must hasten to add, is very, very rare nowadays for Meniere's disease. It is sad, because, I belong to the generation where when we started, I would say in the 80s, 80s and even in the early 90s, but certainly in the 80s, I did a lot of surgeries for Meniere's disease. But notably, I used to do endolymphatic sac surgeries for patients who had good hearing. And after endolymphatic surgery, we would then, if there's no hearing, we'll do labyrinthectomies, translabyrinthine, vestibular nerve sections, so all sorts of things. So my list used to have, in a year, I used to do at least about 50 to 60 cases of surgery for Meniere's disease. Today, if I do one or two even in a year, I think it will be a great achievement. So it's become so rare because of the effectiveness of diuretic therapy. So that's what really, made a difference. We understood the pathology better. And once we started implementing diuretic therapy with sodium restriction, a lot of patients simply improved. That's really the bottom line. So what is the maximal medical therapy? So when we say nowadays that you take up a patient for surgery only if a maximal medical therapy has failed. So what is maximal medical therapy? Nobody's agreed on this. But in general, if you give a year of diuretics and salt restriction, and patient still experiences at least one episode of distressing vertigo a month, or more than 2 episodes of mild vertigo and hearing fluctuation every month, then we consider that the medical therapy has failed. I'll repeat. So at least 1 episode of maximal medical therapy and 2 episodes of mild vertigo and hearing fluctuation, or 1 episode of distressing vertigo. That's what we call maximal medical therapy. So if it still failed, then the maximal medical therapy has failed. So then you are justified in thinking about surgery for this patient. And even then, most of us would start off by giving intratympanic aminoglycosides. And in spite of that, patient is still recurring, then of course, you think about surgery. Now, surgery depends on what kind of surgery depends on how much hearing is there, how much residual hearing is there. So there's something called a 50-50 rule, which has now been replaced by a 70-30 rule. Now, the 50-50 rule was that the patient has at least 50 dB hearing and 50% speech discrimination. So 50% speech discrimination, 50 dB hearing, that hearing is worth preserving. Now, today, because the advent of cochlear implants, this has become a little different. So we say at least 70 dB hearing and 30% speech discrimination. If that is not available, then think about destructive surgery. So if the hearing is preserved, or if there is sufficient hearing, we do endolymphatic sac surgery. Or we can do a selective vestibular nerve section. Of course, this is after you have tried intratympanic steroids. Not intratympanic aminoglycosides, mind you, because remember, there's a good number, 10 to 15% of them may go in for loss of hearing. So if patient has got good hearing, don't jump into aminoglycoside injection. So steroid injection, yes. Otherwise, endolymphatic sac surgery or selective vestibular nerve section where you preserve the cochlear nerve. We'll talk about it in a minute. Now, if the hearing is not worth preserving, that is the 70-30 rule, it does not apply to this patient, then you think about intratympanic gentamicin, which is chemical labyrinthectomy basically, or you do a surgical labyrinthectomy, a classical 3-canal labyrinthectomy, which was first described by Sir Terence Cawthorne, which we now do with a little more refinement with the microscope and drill and so on. And then going further on, you do a translabyrinthine vestibular nerve section. Sorry. Now, what are the contraindications for surgery? You'll never operate on a patient who has only hearing ear. No, you will not touch that ear. Now, if there is a CNS involvement also, in addition, don't touch that patient. Medical condition, of course, is there. And if there is a case where you have bilateral disease, then you have a risk of developing bilateral reflexia and Dandy syndrome. So in those patients, you will not do. Also, don't do on very elderly patients, because in these patients, compensation is very, very poor. So you always prefer patients below 75 years of age. The first endolymphatic sac procedure was described by Georges Portman, 1927. Now, a little bit of history about Georges Portman. He was a Frenchman from Bordeaux, and Georges Portman was the student of Professor Moore. All of you know about Moore's lateral rhinotomy. Okay, he was the man who described the incision for lateral rhinotomy and described the procedure. Moore had a daughter, and only one daughter, was his life and soul and everything. And he gave her ultimately in marriage to his prize student, or his most favorite student, was Georges Portman, 1927. And Moore was the surgeon to the French royal family, Louis XVI. Now, Louis XVI made a drastic move. He moved his capital from Paris to his beautiful palace in Versailles. So when he moved, he asked his entire court to move along with him. So everybody had to move their home from Paris to Versailles. Not many were happy about it. Now, the only exception was Professor Moore, because Moore wrote to the king saying, Your Highness, much as I love you, in fact, this is exactly what he said. He said, much as I love you as a father would love his son, I love my native Bordeaux even more. So I would request you to kindly relieve me of my responsibilities as a court physician so that I can continue to live and die in Bordeaux. So the king was so fond of him, so he was so moved by this letter that he donated the best vineyards. People who have been to Bordeaux will know the best wine in the world comes from Bordeaux. So he gave the best vineyards he donated to Professor Moore. And of course, this went on to the Portman's family because his daughter was married to Portman. So, in fact, the Portman family now, since then, are the owners of some of the best vineyards in all of France. So, this is just an aside story, by the way. But the Portman was, even though he was a student of Moore, who was a very eminent surgeon of rhinology and head and neck, he took up to otology. And he described the endolymphatic sac procedure, which became so popular since then. Now, here, there's vertigo control is around 60 to 90%, and hearing loss is very, very minimal. So, it's a hearing preserving procedure. You choose the patients who has a fluctuating hearing and who responds to the glycerol test, as I already told you. So, this is one of the tests that we do. And if it's positive, then these are the patients who basically you take up for the endolymphatic sac procedure. As this schematic diagram shows, it is usually behind, the endolymphatic sac is behind the lateral semicircular canal and in front of the sigmoid sinus. And this is the area that you will open up. It can either be decompressed or, you can see here, here you can see this picture, lateral semicircular canal, posterior canal, and this is the endolymphatic sac. Is inferior to the posterior semicircular canal, in front of the posterior fossa dura. So this is the area that you will be choosing. It's as a duplication of dura in that area. You may either shunt it or you may just decompress it. Or some people put in a shunt to go into the mastoid or into the subarachnoid space. So that's the area that we are working on. That's the facial nerve here. And you're working behind the lateral canal and inferior to the posterior canal. So that's the area that you will be working on. And you thin it out. Here, of course, is a posterior fossa dura. That's a posterior fossa dura that I'm using the sucker to compress. You can see how we thin it out. Make it paper thin. Make it paper thin. That's the posterior fossa dura. And you can see the duplication of the dura there. That's a duplication. And then you can open up the sac. You can already see the endolymph flowing out. Usually it's under pressure. So it will start leaking the moment you start exposing the sac. And you can open the sac and you can see a small lumen. If you're in doubt, you can even take a bit of tissue for biopsy and send it off, and they will be able to tell you that this is the endolymphatic sac. Now you have two options. Either you can open it up and allow the perilymph to leak into the subarachnoid space, or you can also allow it to leak into the mastoid. Sometimes you can rotate a muscle flap to go into the lumen of the sac. So all these can be done. Vestibular nerve section. Now, one of the reasons why you do that is we know that abnormal vestibular input is worse than no vestibular input. So if you have an abnormal labyrinth, the signals that you get from it is much more disabling than if you have no labyrinth at all. Because then if you have no labyrinth, then the compensation on the other side is easier. But if you have a labyrinth which is malfunctioning, the abnormal signals, now they cause more disruption than absolutely no signals at all. So an abnormal labyrinth is worse than no labyrinth. Remember that. Now, so first person to perform the eighth nerve section was Fedor Krauss from Berlin. Dandy, the very famous neurosurgeon, he also did eighth nerve section for Meniere's disease. And McKenzie introduced the concept of sectioning of the vestibular portion of the eighth nerve. Now, indications: unilateral incapacitating vertigo of Meniere's disease, despite maximal medical therapy in the presence of serviceable hearing. Now, this despite maximal medical therapy in the presence of serviceable hearing is very, very important. So you've done maximal medical therapy, you already discussed it. At least a year you have given salt restriction, diuretic therapy, and so on, and in the presence of serviceable hearing. And if bilateral Meniere's disease, you have to identify which side is more severely affected, which side is dominant. And if there's unilateral peripheral vertigo without the full spectrum of Meniere's disease. So these are all the indications for vestibular nerve section. So there are many approaches. House introduced the middle fossa approach. It's a very simple approach, but many of us don't do it because the problem with middle fossa approach is that you have to lift up the temporal lobe. Dura, and in a small proportion, not a big number, in a small proportion of patients, temporal lobe manipulation may lead to later on to epilepsy, seizure disorders. So because of that, it's generally nowadays not many people like to do it. The simplest, of course, is a retrolabyrinthine or a posterior fossa approach. And today it is done more and more endoscopically. So endoscopic vestibular neurorectal is very minimally invasive, and you can do it. But you can also do a translabyrinthine vestibular nerve section, as we will see. If you do a vestibular nerve section, the vertigo control is excellent. Almost all of them, 90%, 85-90%, your patients will stop having vertigo. You preserve hearing in most of them because the cochlear nerve is still fine. And a small proportion, of course, because of the manipulation of the cochlear nerve, you may have sensory hearing loss. Very, very small risk to facial nerve. Now, this is a classical endoscopic approach. You make a small window behind the sigmoid sinus, below the transverse sinus. So this is the approach that we all use for, say, brainstem implant and so on. You make a small window, open the dura, and as soon as you go in, you will see the vestibular nerve. You can either do it endoscopically, or some people prefer to do it microscopically because it gives them an advantage of both hand manipulation. Now, the vestibular cochlear nerve is one thick bundle. So if you put a small pressure by a blunt instrument on it, you will find a subtle groove between the two. Between the vestibular and the cochlear nerve. You can see the groove here. This is the thing. So here, the cochlear nerve is whitish. The vestibular nerve is grayish. So you section the vestibular nerve, leaving the cochlear nerve. And when the vestibular nerve is fully sectioned, the two ends will jump apart. So that tells you that the vestibular nerve section is complete, and then the cochlear nerve is left behind. So this is how we do. So once again, I'll repeat: a small blunt instrument is used to put pressure on it, and a groove between the cochlear and the vestibular nerve is seen. Of course, the vestibular nerve is superior and the cochlear nerve is inferior. So you start sectioning the vestibular nerve, and you till the two ends jump apart, and then you know that your section is complete. So this is the cochlear nerve which is preserved. The other option is labyrinthectomy. This requires dissection of all the semicircular canals and the utricle and the saccule. So all the 5 neuroepithelial organs, the utricular macula, saccular macula, and the ampulla of the semicircular canals are destroyed. Again, vertigo control almost perfect, 97 to 100. Sometimes you may have very, very rarely, the patient may have some recurrent symptoms. This is attributed to a single ear with severe profound hearing loss. It's usually, basically, you say that there may be a few fibers which have escaped, which are going through the other nerve, like facial nerve and so on, but it's very, very rare. But you must remember that this is a destructive operation where the hearing is completely destroyed. The other, extension of this is a translabyrinthine vestibular laceration. That is, you destroy the labyrinth, you do a labyrinthectomy, and then go further and then destroy the vestibular nerve. So this is a surgical video. It's a sort of incision that we normally do. Some people like to do a C, but whichever you do. But you open up and then harvest a bit of fascia for use later on. That's the fascia being harvested. And then you take it out, okay? And keep this because you need it later on. And after that, you start I'm doing a palmar flap, and you can use that for arbitration later or for closure later. That's a meatortomy being done, and that's extra-aortic canal. A blind sac closure being done. This patient has no hearing. Remember, he's absolutely gone. There's no hearing at all. And you're going to be opening up the labyrinth and intra-aortic meatus, so you're going to have CSF coming out. So you really want to completely isolate the middle ear from the external ear. So that's why the blind sac closure. And you're going to do plug the eustachian tube also. So now the mastectomy commences. Right, so we go deeper, opening to the mastoid. That's a lateral canal coming up into view. Now the entire epithelium of the external canal is denuded because you've done a blind sac closure. You can't leave any skin there, remember? I'm doing a canal roll down because I'm doing a subtotal pederectomy. That's the ossicle. Ossicle is all removed. Drum is removed. Right, now all the skin is completely removed from the external canal. That's the facial canal here. Now that's the lateral semicircular canal. You can all see that. Now starts the labyrinthectomy. So work along the lateral semicircular canal. Remember that every semicircular canal is at right angles to every other semicircular canal. So as we do the labyrinthectomy, you can see the blue lining and opening of the endosteum of the lateral semicircular canal. And if you go along the same axis, you will start seeing now another canal exactly at right angles to it. That is the posterior canal. You'll see it in a minute. It's in a deeper plane. That's the lateral canal, and then of course the posterior canal is now coming up. Superiorly, you have the superior semicircular canal. That's the facial nerve here. Now, when you're, going deeper and deeper into the labyrinth, you will start seeing the outline of the internal aortic canal. Now, that's the outline of the internal aortic canal. You're starting to see through the bone. So, outline the internal aortic canal. Because all this is being done with the facial nerve monitor is mandatory. Yeah. So now the lateral, that's the vestibular nerve. That's the first nerve that will come up. It's a grayish structure. It's a superior compartment, inferior compartment. You can see the CSF coming out. Now the vestibular nerve is slowly cut. It's hanging loose because you already destroyed the end organ, the labyrinth. And if you remove once this is done in the superior compartment, you can see the facial nerve deep inside. That pinkish nerve is the facial nerve. The color of the nerves is very, very typical in the inflammatory meningitis. The vestibular nerve is a dirty gray. The facial nerve is a very healthy pink. And inferior compartment, as the inferior vestibular nerve is being done and removed, being cut and taken out, you can see the whitish cochlear nerve. That's the cochlear nerve. So the cochlear nerve is whitish, the facial nerve is pinkish, and the vestibular nerve is a dirty gray. So you can always, say the nerve just by looking at the color. So here, of course, a vestibular neuronectomy has been done. A translabyrinthine vestibular nerve section has been done, maintaining the cochlear nerve and the facial nerve. Now, what's the significance of this? The cochlear nerve is preserved. So in this patient, technically, you can go ahead and do a cochlear implant and give back hearing if you want. That's a singular nerve, incidentally. So, these are all, this is a classical translabyrinthine vestibular nerve section. The other simpler surgery, which is proposed by Lee et al. And of course, Lone Spahn from Canada, he advocated it, is that you plug the semicircular canals. Now, when you plug the semicircular canal, you have a vertigo control in almost 99% of patients. He initially advocated it, Lone Spahn advocated for BPPV, but then later on he moved on to Meniere's disease. And it preserves the hearing in some patients, at least about 70% of patients, according to him. The other, procedure, which is very simple, is to do a sacculotomy, which is done through the foot plate of the stapes. Basically, very severe episodic vertigo. When the patient has no great hearing, then you can do that. Now, you must also remember that there is a Meniere's syndrome, which is the same symptoms as in Meniere's disease, but it can happen from a whole lot of other diseases like metabolic disorders, allergy, autoimmune diseases, endocrine diseases, and so on. And for that, you need to have an investigative protocol. So you basically get a complete blood workup done, thyroid function test, including thyroid antibodies, an immunological assay, including autoantibody screening, BDRL, TPHA, Lyme, in case it's a patient exposed in South America or North America, particularly some areas, and an imaging. Now, this is a patient who came to me with a long history of Meniere's disease from Delhi, and he had been receiving maximal medical therapy for a very, very long time, no benefit. And interestingly, as soon as he came here, because of his long history and I was suspicious, so I went and got a CT done. And look at that, he had a completely destroyed posterior wall, which is classical of an endolymphatic sac tumor, also known as a Hefner tumor. It's usually a part of the von Hippel-Lindau disease in I believe a third of those patients. This is a surgery. It's a papillary adenocarcinoma of the endolymphatic sac. So basically, the endolymphatic sac is exposed as before. I just want to show you this because, not all Meniere's disease are Meniere's disease. So you have to be always suspicious about it. That's a tumor just coming out from the posterior fossa here. And, just stripping it off the dura. Came out well. The man is doing well, actually, for many years now, almost more than, I think, 15 years since he had the surgery. He's perfectly fine. So this is just to show you that there is this entity of what is known as a Hefner tumor, which can, present with endolymphatic hair drops. And if you have a resistant endolymphatic hair drops, always image the patients to find out why they are not responding. Hearing habilitation in Meniere's disease, you can, in a patient who's got residual hearing aids, cochlear implants if there is an extensive destruction. So, it definitely shows that in these patients, there may be improvement. Now, this is a patient who underwent a labyrinthectomy with cochlear implantation. So, simultaneously both are being done. 3-canal labyrinthectomy that I told you about. And at the same time, in fact, this is a very unusual case because a very high jugular bulb reaching almost covering the round window membrane. That's the round window. And the jugular bulb, you can see the moment I touch it, it bleeds like anything because the jugular bulb is completely covering the round window membrane. So I had to actually push it down and then make a separate cochleostomy and go in. So this is an interesting case. It's a partial video. So you can see that I'm just compressing it and then going ahead with the labyrinthectomy. So a very contracted mastoid, high sigmoid sinus and jugular bulb, anterior sigmoid sinus and jugular bulb. So so you can actually do it as one stage or a two-stage procedure. Both can be done. So you've done a subtotal petersectomy with blind sac closure. That's a jugular bulb. Again, you can see the bleeding there. But you don't have to get panicky about jugular bulb bleeding because it's a venous bleed, so it'll stop with a little bit of compression, gel foam and little pressure, it'll stop. It's not a very big nuisance. So after that has been done, then this patient, once the bleeding was controlled, that's again a blind sac closure and all that. Subtotal petersectomy is blind sac closure. You see it's a very bloody field. Okay, so now the labyrinthectomy. That's the lateral canal, posterior canal. Now, when you're doing a cochlear implant, we generally avoid opening the intra-auditory meatus. We don't do a vestibular nerve section in these patients. We stop with a labyrinthectomy and then go ahead and do a cochlear implant. There's a small risk of damage to the cochlear nerve. And mind, if you do a damage to the cochlear nerve, the cochlear implant won't work. So we don't take the additional risk. So generally, we stop with a labyrinthectomy, 3-canal labyrinthectomy, and then go ahead and do so that's the lateral canal, posterior canal here, and the superior canal is there. So all the 3 canals ampullae are destroyed. But we stop short of the internal auditory meatus. That bleeding is from subarcuate artery. And once the bleeding stops, then you know that you are very, very close to the internal auditory meatus. Okay, that's a typical 3-canal labyrinthectomy. We destroyed all the 3 semicircular canals. Now I'm doing a cochleostomy. That's the jugular bulb. So just above that, depressing the jugular bulb down, we do a cochleostomy to open the lumen of the cochlea. That's the cochlea getting open now. Yeah, that's the cochlea open. So now the implant can be performed. That's the implant going in. So in this patient, simultaneously, we've been doing a 3-canal labyrinthectomy, blind sac closure, subtotal petersectomy with a cochlear implantation in the same time. So we have destroyed the labyrinth, so there's no vertigo, but we have preserved we have restored the hearing using a cochlear implant. So nowadays, there's no reason for a Meniere's disease patient not to have hearing. So that's the important message in this video. Vestibular implant. Now, this is something which is coming up more and more, and it is useful for patients who have bilateral vestibulopathy, where they have typical Dandy syndrome, where both sides are affected and both sides are areflexic. This is terrible because in Dandy syndrome, the patients, when they are walking, they have oscillopsia. The whole visual field, the whole world in front of them will be moving up and down, as if they're walking on a horse, and the whole world is moving up and down. Imagine a situation like that. It's very, very distressing, these patients. So for them, if you introduce this it looks like a trishul. You see, look at the three, each goes into one semicircular canal. And you can also combine it with a cochlear implant nowadays. It's also possible that you can put each into one ampulla or semicircular canal, superior, lateral, and posterior. And you can also introduce a cochlear implant in the same patient if you need. And there's a external device, which is a gyroscope, and that will collect the information from these three, with and take the information from outside and feed it into that, and these patients get a sense of balance with it's always done on one side, of course, so we combine with the cochlear implant. What about future? A lot of new things are happening, gene therapy, targeted drug delivery, gene regenerative medicine. Nowadays, this anti-secretory factor is a very, it's a new word, it's a new fashion, I think. Everybody has to know something about it. It's a factor which is secreted by the pituitary, which has an anti-diarrheal effect, basically, if you want to call it that. Basically, it reduces the fluid secretion by the intestines, but it has also shown a lot of anti-inflammatory effect and in many conditions, and it's also been shown to be effective in Meniere's disease, one of the theories which is now coming up. Artificial intelligence, I already told you about cochlear implant combining with vestibular implant, and endotyping, to predict the disease laterality and progression. Some genes have been identified. The familial Meniere's disease, is an autosomal dominant with an incomplete penetrance, and you have all these genes implicated. But you may also have sporadic Meniere's disease. Some genes are now coming into fore. I'm not going to go into details of that, but remember, we have identified genes for every structure in the cochlea. The TECTA, GJD3, and OTOG. These are the genes which are responsible for the tectorial membrane. The immune system inflammation genes, NFKB1 and TLR2, and vascular endothelial permeability genes are common for the whole body. And inner ear homeostasis is the DTNA and FAM136A. These are the genes which now are, very hot in research. So to conclude, it's usually a disease diagnosed by its characteristic clinical features. Even today, diagnosis is by history and by the presentation. And of course, we have a lot of investigations which are now come in to help, and new investigations are now coming in. Thorough evaluation, including imaging, is essential, mainly to exclude other causes which can mimic Meniere's disease. A vast majority of patients with Meniere's disease respond to conservative management, such as dietary, salt restriction, and medications. Just because I showed you a lot of videos, don't think that's the line of management. Mainly the salt restriction and diuretics. And intratympanic treatment, if this fails, and only if maximal medical therapy fails, is there a role for surgery, and that is in a very, very small number of patients who do not respond to maximal medical treatment. Now, these are my references. I'll stop here, and if there are any questions, I'll be more than happy to answer.
Salil sir. Thank you very much, sir.
Please unmute and ask any questions, sir.
Thank you very much, Professor Mohan Kameswaran, sir. It was an elaborate talk, and thank you very much. The forum is open for discussion. Anybody can ask any questions. You can
unmute. Salil Kumar sir, you can unmute and ask question. Salil Kumar sir, unmute.
Dr. Mohan. Hello.
Can you hear me?
Yes.
Yeah.
Good
Somebody
evening,
has
Dr.
asked about indapamide dose. So indapamide is given initially in the acute phase. The patient comes with severe vertigo. We give every day for about a week or 10 days till the vertigo settles down. and along with, of course, vestibular suppressants like, prochlorperazine, and so on, Semetil and so on. Now, once that settles down, then indapamide is made into alternate days for a couple of weeks, and then made into twice a week. And twice a week, we continue for a few months, definitely, till the patient is completely asymptomatic for at least about 5-6 months. And if they are asymptomatic for 6 months, then I usually tell them to have once a week for another 6 months or so, and then stop. But salt restriction to less than 2 grams, that continues for life. So that's the most important thing.
What about Lasix? You usually give Lasix.
Lasix, nowadays we don't give so much, because thiazide diuretics and indapamide is what we prefer. Lasix a little too much, I think, for that's the reason why. But Lasix, furosemide, is used in testing for Meniere's disease. For all the, instead of glycerol dehydration test, other test which can be done is furosemide test. So you can give furosemide and you can do the audiometry, and about 90 minutes later, you will find that there's an improvement in audiogram in the early stages. And these are all good cases for endolymphatic sac surgery.
Good evening,
Thank
Dr.
you,
Mohan.
Mohan.
Yeah, Dr. Panikar, yes, John.
Yes. Actually, I am sorry. When we joined this Zoom, by default, that speaker is on.
Oh, no problem.
So that's what happened.
No problem.
Okay. I have two things. Just what about Diamox as a diuretic? That is one thing.
Yeah, that's the thing.
And number two, see, in your experience, there are Meniere's syndrome cases other than proper Meniere's disease.
Yes.
Which is more common, the Meniere's disease or Meniere's syndrome like problems?
Yeah, Meniere's disease is definitely more common than Meniere's syndrome. I think Meniere's syndrome is certainly not so common. But you can have autoimmune induced Meniere's disease, which is what we call Meniere's syndrome. But Meniere's disease is definitely much more common. Generally, acetazolamide, John, we don't use so much nowadays. The reason is the toxicity. The problem with acetazolamide or Diamox is, of course, that it's a very good, it's very good for lowering the CSF pressure. And similarly also endolymphatic pressure, or perilymphatic pressure, sorry. The problem with Diamox long-term usage is it leads to a very, very unusual situation of hypokalemic acidosis. Generally, hypokalemia will be associated with alkalosis. That's a common association. This is only two situations where you can have acidosis associated with hypokalemia. One is renal tubular acidosis, another is after diuretic therapy with acetazolamide. So these patients become acidotic after a long-term usage. And that leads to a whole lot of other problems. So for this long-term acetazolamide therapy is generally not advocated. Even where we want to lower the CSF pressure using acetazolamide, we generally don't advocate beyond a few weeks, 3 to 4 weeks. Beyond that, if you want to lower it, much better do a shunt. Generally, acetazolamide long-term therapy is not encouraged nowadays.
Another thing is it is numbness of the lips and fingers. Many people, patients.
Headache. Another common thing. All of them will have headache. But acetazolamide has got a real role. One, as I said, whenever there is a high CSF pressure, you want to lower it. It's a very good drug. And also when you're going into high altitude, like you're going into, let's say you're going to Ladakh for a holiday or something. Then for a short period, if you use acetazolamide, it's very, very good for the lung to to cope with the low oxygen situation. So those are the situations where acetazolamide is really somebody, Sophia Amalnathan, is asking, sir, how long can we keep the patient on medical management? As I told you, Sophia, generally maximal medical treatment refers to an active medical treatment for about a year. And within a year, if a patient is showing improvement, then of course you continue. But if after a year you've still not shown any improvement, then those are the patients you start thinking about other modes of management, whether intratympanic or even into surgery. But at least a year of medical management is considered as mandatory. I hope it answers your question.
Mohan, is it the treatment is lifelong? Like,
Indapamide, generally I give them for few years, 1 or 2 years. And after that, if they're asymptomatic, I tell them stop it, but continue. The salt restriction is lifelong. Salt restriction is lifelong. And it's very important because we Indians love salt. Every damn thing we put salt and we cook, everything is salt, salt, salt. Even our sweets, Indian sweets have salt. Remember that. Always tell the patients. You go buy some jalebi from the shop, it'll have salt. You buy Mysore pak, it'll have salt because they add salt to make it sweeter. So it's very, very common. Other thing is even things like biscuits, which they buy in shops, they all have very high sodium. So keep telling them again and again. Because they'll say, sir, I never have salt. And then you ask them, do you eat biscuits? They say, I eat biscuits, but biscuits has got salt. So you have to keep telling them, specifically about every food item. But sodium is the culprit.
Mohan, thank you, Mohan, for a long and elaborate talk.
Yes,
as
yes.
you said.
Dr. Mohan, one more question.
Yes.
Is there any role for vestibular exercises in chronic
yes.
miniature syndrome?
Absolutely. That's the most important. That's the most important. No doubt about it. In a patient who does, who's come out of acute phase and is on a long-term follow-up and management, the only thing which really makes a difference is vestibular rehabilitation therapy. And this actually Anirban goes on talking about, now Vishwas also goes on talking about it. This is all very, very, very important. Long-term management is vestibular exercises. So that's all. There's no doubt about it. Absolutely.
Yes, yes.
Some more questions in the chat box, sir. Please.
Let me check up.
So this is Dr. Sarun.
Yes, Sarun.
I have one question.
Yes.
So, see, the endolymphatic sac decompression, many international faculties are telling that it might occlude and again that can cause Meniere's again.
It can.
Second thing is that there is a chance for maybe like a less percentage of sensory neural hearing loss also can occur, right, sir?
Yeah. Yeah.
So how do we know actually if suppose we have done an endolymphatic sac decompression and later on we came to know the patient lost the hearing also, then it will be again a problem only, right, sir?
Absolutely. You are very good questions. See, the problem with endolymphatic sac surgery is that, there was a very famous paper by Mirko Toss and Jens Thompson. This was almost 25, 30-year-old paper. So where they did sham surgery, they did sham surgery. They just opened the mastoid, cortical mastoidectomy and closed up. And compared with endolymphatic sac surgery, they said the results are the same. So this produced a lot of criticism and much criticism against endolymphatic sac surgery, saying that this whole surgical effect of endolymphatic surgery is placebo. So, it's not any better than if you do a simple cortical mastoidectomy and close up, the same results. So what's the big difference of doing endolymphatic sac after so much of surgery? So the actual, it was for a long period, there was a lot of, I would say, in the 2000, 2010, 15, that period, a lot of criticism based on this paper from Denmark, from Copenhagen, from Mirko Toss and Jens Thompson. But then later on, there were some very effective studies which came from Australia, which showed intraoperative electrocochleography. And there, they very significantly showed, especially Professor Gibson, he showed that if you are doing an intraoperative electrocochleography and you're doing a endolymphatic sac decompression, during the surgery itself, you can show the reversal of the electrocochleography. Now, that is very conclusive evidence. So, they said that, okay, I open the endolymphatic sac, let out the endolymph, and there is a change in the electrocochleography. So the SpIP reversal is getting changed. So that was a very conclusive evidence. So that again brought back the endolymphatic sac surgery to fore. Now, generally, endolymphatic sac surgery, more than 75-80% of patients, will have relief of vertigo. But how long this will last, we cannot say. It will last for a few years. I have endolymphatic sac surgery patients whom I operated 30 years ago, 40 years ago. They're still fine. They're still going around fine. But I also have patients, some of them after 5-10 years have come back saying that, I'm not better. So then I've had to revise the procedure or do some other procedure in this patient. In fact, the next thing I do, if this fails, is to go in and do a selective vestibular nerve section for these patients. So you have to tell the patients, discuss with them, explain to them that this may be very effective in the long run, or sometimes it may be recurrence. There's a small percentage of recurrence. And if it does recur, then we have to go for more invasive procedures. The advantage is it's a very simple procedure. It's very atraumatic, and it gives fairly good results in about 3/4 of the patients where there is control of vertigo, and we preserve the hearing in most of the patients, more than 90-95% of the patients. Small number may develop, but we don't know whether it is due to the surgery or whether the disease itself is progressing and causing a hearing loss, isn't it? So we really can't swear by that, but generally speaking, it's a hearing preservation surgery.
So what about this Meniere's diseases that is written in books and all?
Yeah, this is Meniere's disease. So the other one is
Meniere's devices.
Meniere's. Oh, Meniere's. Okay. Well, it is very interesting. Meniere's device was devised by a medical student, actually, as part of his summertime project in the UK, and it actually gives positive pressure pulses, into the middle ear, in the round window membrane, and so on. It's now no longer used. It was brought in with great fanfare. A company actually took over and then started marketing it, but it really doesn't work. So it's now gone out.
What about this gentamicin? Some people are like, some papers are telling that gentamicin may not destroy the hearing as such.
It does in about 20-25% of patients.
Yeah.
So if you have a big study, if you're doing 100 patients, in about 20-25%, it'll damage the hearing to some extent or the other. So you have to always get a consent for hearing loss from the patient. You're going to be doing it.
Okay.
You don't know which
Okay,
is 20% is going to be. Right?
Yeah. Okay. Thank you. Thank you so much.
Dr. Mohan, one more question.
Yeah.
Hello.
Yeah.
Yes. How many percent of Meniere's disease have bilateral problems, and if so, will you go for a vestibular neurorectum?
It's a very good question. If you follow Meniere's disease patients for many years, so if you are a practitioner for 30-40 years, like John is or I am, then you will see that most of the patients of your Meniere's who had come initially with one side are starting to show features in the other side also. Roughly about 10-15% of patients will start showing the second side every year. So in other words, if you have 100 patients with single-sided Meniere's, every year you can expect 10 out of 100 to be showing one side, extra other side also getting involved. So over 10 years, maybe, they'll have be full complement. But if you follow them long enough, maybe that's a bit of an exaggeration, but if you follow them long enough, 20, 30, 40 years, invariably many of them will start manifesting with bilateral disease, which is why before we do a destructive procedure in 1 year, we always have to be very, very careful. What if this develops on the other side also? So you have to be very careful about that. That's one of the considerations. It's a very good question.
Absolutely, because with the advent of this cochlear implantation, I don't think destructive surgeries should be kept at the minimum possible, because
absolutely.
anytime we will have to go for a cochlear implantation.
Absolutely, I agree with you entirely.
Yes, thank you.
There are few questions in the chat box, sir. How can you differentiate Meniere's disease from other causes of dizziness?
Yeah, I think I told you that. You have all the classical features of Meniere's disease, diagnostic features. Predominantly, it's the presentation. It is fluctuating hearing loss, low frequency hearing loss. All those are very, very classical of Meniere's disease. A Meniere's disease patient will present to you classically. You cannot miss the diagnosis. They'll come and tell you ear pressure, vertigo. See, after all, a patient who's had a vertigo with tinnitus and hearing loss, there's only a few things. What can it be? It either is a Meniere's disease, or you have a vestibular schwannoma, or a patient has got labyrinthitis. So they're very, very limited. So a patient who's got a fluctuating hearing with unilateral hearing loss and tinnitus and vertigo, which is episodic, lasting from a few minutes, but something like 15-20 minutes to up to about 10-12 hours, with classical vomiting and all the anxiety, palpitation, sweating. That's Meniere's disease. You cannot miss it. There's nothing, no two ways about it.
Dr. Mohan, one symptom I usually see is they are intolerant to loud sounds. Many of these Meniere's.
Naturally, because of the high drops. Oh, that's classical.
Eye drops.
The recruitment.
Classical.
They have the recruitment. That's
Recruitment. Absolutely. Yes.
So what is the dosage of indapamide?
Indapamide is, it comes in a fixed dose, so a single tablet, and this tablet is, generally you're giving, it's called Latilic XR, sustained release. It's given once a day, one dose every day, one tablet every day, for about 6 or 7 days, till the acute phase settles down, along with prochlorperazine generally, with many as, we give along with Stemetil. So in a week or so, you reduce it to alternate days. And that goes on for about 2 weeks or so. And then after that, twice a week usually for a few months till everything settles down. And generally I give for 6 months to 1 year, twice a week. And after that, if they're fine, then maybe once a week and then stop it slowly. But the important thing is throughout this period, salt restriction is, very, very important. Ultimately, it's a salt restriction is important. Now, all the diuretics are adding on to that. So we have to keep that in mind.
Is there any scoring system on symptoms of pre and post-op or any other procedure?
Well, there's really no great scoring system if you want. If you want, you can start it. But I mean, vertigo is such a classical symptom. A person who has vertigo has vertigo. Simple. A man who's having severe vertigo and vomiting, whether he's got grade 3 or grade 4, he's not going to be very interested. He's going to want his vertigo to stop. So I think scoring system in vertigo are probably not very, important. I think it's almost an all or none law. Either you have vertigo or you don't have vertigo. So you really want to control the vertigo in the acute phase. And Meniere's disease, it can be pretty violent, it can be quite violent. Some of them will come literally curled up, like a snail, that much of vertigo they may have. So you have to, basically control the vertigo. That's your priority. Even a little vertigo is very, very unpleasant for the patient.
What is the role of beta-histine in Meniere's, sir?
As I told you, it's very controversial. Both there are some very strong proponents, strong opponents. I think the jury is still out. But there are some countries like US where you can't prescribe. It's not FDA approved. But having said that, we all have patients who will swear by beta-histine. They will have beta-histine and they'll be very happy about it. And you carry on for months. And even if you tell them to stop it, they won't stop it because they're so dependent on it psychologically. So, I think if you go by hard evidence, scientific evidence, based on double-blind prospective studies, Cochrane review and so on, the evidence is not yet forthcoming for beta-histine. But there is a lot of subjective evidence and there are a lot of patients who actually use it and benefit from it. So, it's your call, basically.
A patient with the fluctuating hearing and vertigo, but the atypical audiometry, how aggressively do you pursue?
You can't. Pure audiometry is not diagnostic at all. Many years, these are the patients in whom you have to do more advanced tests like electrocochleography and so on. In these patients, if you do electrocochleography, you will have a classical pattern, a lazy W. So that will give you the diagnosis. So pure audiometry is only to an extent. You can't swear by it. There may be many patients with almost normal hearing with many early stages.
Any eventual burnout phase of Meniere's disease?
Final phase, yes. Eventual burnout is when they are dead labyrinth, no vertigo, no hearing. That stage, of course, the patient is completely free from vertigo, but also has no hearing. That's the last stage, end stage of Meniere's. Many patients will wish for that, actually. They will rather lose their hearing and but have no imbalance. So those patients, you can take up from cochlear implantation, give them hearing.
Okay, sir. So I have one question. How will you diagnose physically? You said in postmortem report. Is there any postmortem is going on in any countries of the Meniere's?
For Meniere's, there have been a few patients. Not because they died from Meniere's, they died with Meniere's, with some other disease. And then when postmortem was done, the cochlea has been studied. There's quite a number of those cochlea, particularly some centers in Europe, some centers in the US. And they have shown that, they have studied very extensively the eye drops and shown all the pathology which has been done. So there's enough reports. But this is all because the patients have donated their their cochlea for studies, knowing that, but they didn't die from obviously from Meniere's disease. They died from some other cause, but they had Meniere's disease. So
is there any association of Meniere's patient group or something like
I
in
don't
any
know.
country
Maybe
outside?
there is. Maybe there is. But the Pulitzer Society and the Barani Society both have a lot of what can I say? A lot of dialogue on Meniere's disease. Barani Society every year, every 2 years they meet, and then they have quite a lot of discussion on Meniere's disease, presentations and so on. Also in Pulitzer, I have myself presented a lot of cochlear implantation in many years and so on. So it's a very hot topic many years, in spite of the fact that it's such an old topic. It's such an old disease, but still we know very little about it. If you think about it, that's why it's such an enigma and such a challenge. It's still a lot of work needs to be done in Meniere's disease.
One more question which I asked last time, the potassium. The potassium overload. I have one patient who consumed a lot of banana plantation every day because he got a plantation. And once he stopped eating, she stopped eating the bananas, her symptoms recovered. Is there any relation of potassium?
Yeah, well, it may be, because ultimately it's a sodium-potassium, imbalance, and the sodium gets pushed into the potassium channel. That's how it works. Rather, the potassium gets pushed. So, you're having the leak, and the sodium-potassium pump is failing. So maybe the potassium overload is, reducing the sodium. I don't know. It might be, but if it's working for her, well, good for her. Better take bananas than be taking medicines.
Thank you very much, sir. Any more questions?
Dr. Mohan.
Yes,
I am Dr. Gopumar.
Hello, sir. How are
Good
you?
evening, sir.
Good evening.
Sir, have you used the diamond hydrogenate in your practice for?
No, I haven't, but I know it's been used. I have not used it personally. No.
So I have used it. Now instead of cinnarizine, now I use diamond hydrogenate. I think it's lesser sedation and is more tolerated.
Yes.
And I have seen this so many neurologists who are treating Meniere's disease. They prefer diamond hydrogenate rather than.
Yeah, it's an acute vestibular suppressant, so it'll immediately stop the vertigo. Only thing is, long term may not be used because of the the possibility that the compensation may be reduced in these vestibular suppressants. But yes, it's a very good vestibular suppressant and very also what can I say? Very limited, very minimal toxicity. So it's a good drug.
Dr. Mohan, some patients with Meniere's, they also have some problem with positional vertigo also. Have you seen such patients?
Yes, it can happen. And it stands to reason. When you have endolymphatic hydrops, then they can even have the cuprolithiasis as a part of it. So they may also present at times with positional vertigo. It's well known. It can happen.
Okay.
Association is well
Okay. Thank you.
Dr. Mohan.
Yes.
Actually, regarding the diamond hydrogenate, regarding the question of Gauma, diamond hydrogenate has more parasympatholitic effect. So dryness and other symptoms can be more. So that is why it is not so popular. But it can be definitely, it has some effect. But it is a more parasympatholitic.
It's a vestibular suppressant. It's an acute
suppressant as well as a parasympatholitic.
Yeah. And
so
because of that, the long-term usage is not encouraged because that will reduce the compensation. That's the problem.
Particularly in BPH patients and definitely it can produce a parasympatholitic effect. Retention of urine and all. So definitely in small dose it can be given, but that is the one thing which it is not so popular.
Sir, last two questions from the chat box. Meniere's disease patient have a severe to profound hearing loss. Is it possible to have a severe to profound hearing loss?
Yeah, of course. Have severe to profound loss. Some of them no hearing at all. They can eventually lose completely hearing, and in that case, you just have to put the cochlear implant. Nowadays severe to profound loss is a good indication for a cochlear implant.
Yeah. Any role of diazepam in Meniere's disease?
Yes, in acute phase, in a severe vertigo, along with vestibular suppressants, diazepam is given to allay anxiety as an anxiolytic. Many of them have anxiety as an overlay. So
Yes,
it's
sir.
also given, but not as a vestibular suppressant, but as an anxiolytic, in addition to a vestibular suppressant.
Any treatment of treatment of Meniere's in pregnancy? This must be the last question.
Not restriction, same than any other person. Generally, in pregnancy, Meniere's disease, actually the attacks will come down. Probably the hormonal effects. They'll have less Meniere's disease if you see Meniere's pregnancy. But if they have, just gives them a mild diuretic. Most of the diuretics, like I said, diuretics are safe in pregnancy. And you can also, tell them to go easy on salt and so on.
One more question has come. Do you think machine learning models using audiometry, vestibular testing, and clinical history would predict which patients will respond?
That's a very difficult question to answer. I think your natural intelligence will still, prevail over machine learning, over artificial intelligence. So I think the foreseeable future, you're going to be diagnosing the patients yourself. AI may be helpful, in predicting models. I don't think you're going to go by that, at least for the predictable future.
Thank you very much, sir, for the elaborate talk on Meniere's disease. Thank you so much. We are greatly blessed to have you.
I'm very grateful to you for that. Thank you so much, Pradesh. Thank you.
Thank you. I think we'll end the Zoom meeting. Thank you so much.